Liaison program here at UK Healthcare. And I'd like to thank you for joining us today and taking time out of your busy schedule to discuss the important topic of trauma-informed medical care. Before we get started, I'm going to go ahead and go over just a few general housekeeping rules. Can you do next slide, please? And so that we can better facilitate networking and follow-up communication, if you wouldn't mind to put your name, title, organization, and email address into the chat box, or you can message me privately, that's fine. That way we'll have your contact information for follow-up for slides and video links. If you signed up under your initials, if you could just change your name to your first and last name and maybe your organization, that would be helpful too. All your microphones have been muted. Towards the end of the presentation, we'll be taking questions. You can put those questions into the chat box, and then we'll kind of address them from there. And then I would suggest putting your view in speaker view so you can see the speaker and the slides together. We are recording today's session, so I'll be sharing that video link out with everybody that I have their contact information for later today. And just as a general reminder, this is a community-wide forum, so please don't share patient-specific information on this venue. And with that said, I'm going to turn it over to our host today, which is Dr. Scotty Day, our physician-in-chief for Kentucky Children's Hospital. Thank you.
Good afternoon, everybody, and welcome to our chair town hall. We appreciate the opportunity to come to you today to talk a little bit about another topic. We appreciate people sending topics, and to Michelle's point, please send other topics, as that is what guides our decision. So I'm not going to spend a lot of time talking because I'm going to turn it over to the experts. So I'm going to start by introducing Megan Marsack. For those who don't know, Megan Marsack is our Associate Director of the Center for Pediatric Traumatic Stress. She's a faculty member in the Division of Pediatric Advanced Care Medicine, and she's also an expert in trauma-informed care. She's a ped psychologist that has been with us for many years, and she's really been a leader in that field. So with no further ado, Dr. Marsack.
Thanks so much. We're very excited to be here, and I will introduce my co-presenter, Annie Marcinko, who's a fantastic nurse who's been here for lots of years and lots of different roles along the way. So she's got great experience across the board caring for kids, particularly. A quick disclosure before we get going. I am CEO of the Celly Coping Kit and the Celly Coping Company. I'm also a co-author of the book. These are a couple of resources that are in our resource list that we're going to run through at the end of the presentation. So just to give you a sense of where we're going, we're going to talk a little bit about what medical trauma is and describe how it impacts our kids and families and also ourselves as medical providers. We're going to talk about how to recognize emotional trauma symptoms and talk about some techniques that can be directly integrated into daily practice to try to minimize the impact of medical care on our kids and our families. So when we have these kinds of discussions and these kinds of talks, I think it's always so much more interesting when you think about your own patients and the kids and the families that you serve. If you serve beyond kids and families, a lot of this information is also applicable to adult care. We're doing actually a little bit better with our kids and families and thinking about trauma-informed care. Our adult care is even a little bit farther behind as far as figuring out how do we minimize traumatic aspects of medical care as well. So as we go through, if you think about the kinds of kids that you see, or if you kind of have a patient in mind, that can be really helpful as you think about how you might apply some of this to the work that you do. So just to start off, when we talk about trauma-informed medical care, what do we mean? So the big kind of long fancy definition is, psychological and physiological responses of children and their families to pain, injury, serious illness, medical procedures, or invasive or frightening treatment experiences. So when we talk about medical trauma, it's both, we're talking about emotional medical trauma here, and it's both those reactions to diagnosis, reactions to the disease or the medical care itself, as well as treatment as well. But how I really like to describe it in a much more simple way is it's these emotional reactions to scary medical stuff. And that can include emotional reactions that are expressed both kind of through feelings and that sort of pathway, as well as physiological reactions. So when we talk about trauma-informed care, we think about kind of these four different components. The first is realizing the prevalence. So realizing what people are coming in with when they come into practice with us, when they come in to receive medical care. What are we bringing to the table as well? So none of us have grown up in a silos where nothing has happened. So thinking about what are the things that we're bringing to the table that will interact with what our patients are bringing to the table that might impact the way that we deliver medical care or the way that our patients experience medical care. We think about it both in the terms of their patient themselves, but also siblings, caregivers, or other family members, other people who could be affected by medical trauma as well. Then once we realize kind of how common trauma is, what we're coming in with, what's happening once we're here, we think about how do we recognize signs and symptoms? So what does it look like in our kids? What does it look like in our families? And what does it look like in ourselves and in the medical teams that we support? So if you're leading medical teams, you might see some trauma reactions pop in our staff as well. So thinking about that as we're implementing trauma-informed care. And then the third and the fourth one kind of go together, thinking about responding and resisting re-traumatization. So that's really what are the actions that we can take to minimize the impact of the medical care that that medical care can have on kids and families and ourselves and our providers that we support as well, and resist re-traumatization. So some of our kids come in with things that, depending on how we implement medical care, we might be triggering or kind of re-traumatizing as well. So thinking about those 4 different components as we think about how can we implement trauma-informed medical into our daily practice. So starting off with realizing, so thinking about how widespread trauma is and understanding like what are the paths for recovery. So there's 2 different pieces to this. We think about exposure prior to the child or the family landing in our service or landing for our care. And so we know that kids and families go through lots and lots and lots of things prior to arriving. They might have things like abuse histories, things like ongoing chronic stressors in their lives, might have some other difficulties with toxic stress, where they're looking at, kind of that ongoing challenges with getting resources, ongoing challenges of poverty mixed in. Some of our kids have been exposed to community violence. Some of them might have had a really bad experience with a medical procedure or medical person before they landed in our care. So it might not have anything to do with our team, but they kind of went through something really difficult before they came into our care. So we think about what our kids are coming in with, what are our parents coming in with. For many of our pediatric providers, a lot of us went into pediatrics to work with kids, but we know that in pediatrics, we work with parents a lot as well. And sometimes parents' emotional health reactions drive kids' emotional and physical health, and can certainly make those appointments that are tough for kids better or worse, depending on the parent's own coping skill set, if they're having anxiety or they're having reactions. And then thinking about also what are we coming in with as providers, what has happened in our past lives, what drove us into the profession that we're in, are there things that we're drawing from that we have to make sure that we're not kind of living in that can affect our care? Are there other really tough things going on in our lives that we need to be aware of so that we can navigate that as we manage medical care for our patients and families? And then the other piece is the potential for new trauma or re-traumatization. So really common things that we see, kids and needles, goodness, with the vaccines. I think sometimes even just coming to some of the medical facilities, sometimes sedation can be really scary for kids or families. Sometimes MRIs can be really scary. So some of the things that we do every single day as part of our standard care might be the first time that family's experienced, or could potentially bring up something from another negative experience. So for example, you might be sending a child for an MRI, but last time somebody in the family got an MRI, they ended up getting cancer, or they had like a really bad outcome. So we don't necessarily know what that's going to be like for all of our families. So just realizing the kind of care that we're doing, that sometimes is promoting beautiful health in our kids and families, or potentially life-saving at times, but can still be potentially emotionally traumatic for kids and families. So thinking about what everybody's coming in with. So we know these days, particularly coming back after COVID, some of our kids are really struggling with school. Some of our kids have trouble with bullying in school. Some of them are don't have great school systems. Not all the schools are safe. Some of our kids and families are coming in with beautiful family support and an amazing network. Others of our kids and families are coming in with a lot of family challenges, and we don't always know what's all in the background for our kids. As we mentioned previously, sometimes some kids, have had some negative medical experiences in the past. And so sometimes when they come to us, they might already be a little bit nervous, or some of them potentially completely traumatized from some of their past experiences. A lot of our families face financial challenges and financial barriers, and thinking about, as we're asking them to implement some sometimes very complex medical regimens, what are the other things that they have to manage on a daily basis to make sure they're keeping a roof over their head or keeping food on the table? One of the things that's been particularly even more challenging, if you serve kids that are in the hospital with COVID, is there's been so many visitor restrictions. So something that we previously did prior to COVID is, to help keep emotional health up, we invite kids' friends in, we have as many visitors as we can, keep kids engaged and social, and like have lots of different family members in. And that's been a lot harder to do in context of COVID. So it's, leading to some more isolation, even in some of the medical appointments, outpatient. Now we're still often asking only one person come, and, maybe not having as many supports as kids and families are used to. Sometimes the circumstances around the injuries or illnesses, we're not always sure what all the kids are coming in with. Sometimes even if it's an accident, sometimes the accident can be perceived as very potentially traumatic for kids. It was maybe very, very scary, or they didn't know where their parent was when they got hurt. Those kinds of things they come in with. And then figuring out too, for our families, how are their hospitalization experiences going? So if they are somebody that needs hospitalized, what is that pathway? How long are they in the hospital? What kind of supports? If mom or dad is here, does that mean that they don't have as much income coming in? How are siblings? Like all the different pieces of things as we navigate care. And this is one of my favorite scary pictures, I would say, that I always like to show, because we think like as medical providers, we look kind of creepy all garbed up, and now we've got COVID garb up sometimes as well. And so thinking about, even as an adult, seeing those people kind of stare at you, look at you, kind of move forward to suffer some of the procedures, if we don't know what's going on, that could be really scary. So thinking about what are the things that we're doing, how are we communicating to our kids and families in that context? What we expect as far as trauma responses, and again, we're talking about emotional trauma, is that there's some kind of incident, injury, or illness, or this could be in context of a general pediatrician appointment as well. So even in context of well visits, if kids are coming in for a vaccine, or the kids that are just really afraid of the medical offices, generally we have distress that increases, and then it goes down over time. A lot of kids have good coping resources, or they've got really good supports in place, and we manage to decrease over time. The kids and the families that we are more concerned about are the ones that don't come back down. So they have some kind of initial challenge, and then either every time they come back for their pediatrician visits, or every time they come back for medical care, they're having ongoing challenges and ongoing distress. And we do have a subset of kids and families where this increases even further, so that their distress goes up over time. So these are the kids that we're really looking to try to intervene with and help. The other thing that can be really challenging for our families is a lot of our families don't just have one incident or one acute event. It's ongoing medical care. Sometimes there's scary medical procedures. Sometimes there's intense pain associated with some kind of different medical illnesses. Sometimes a parent also might suddenly lose a job. So you have that then kind of put in the picture of what does this look like for kids and families, particularly with chronic things. For our kids that don't have chronic medical conditions, just thinking about each time they come back to the pediatrician's office, what does that look like for them and how are they experiencing it? So thinking about how common this is, and thinking about in the practices that you serve and the kids and families that you serve, we know that about 30% of kids that have either acute injuries or chronic illnesses and their parents demonstrate significant trauma reactions. We also know these rates are similar, if not higher, for siblings of kids with chronic conditions. So when we're thinking about serving kids, serving families, taking a trauma-centered and a family-centered approach, making sure that we're aware, our siblings in the home, are the siblings getting the support that they need as well. And then longer term, our rates vary substantially, anywhere from around, 10 to 3/4 of our 10% to 75%, 3/4 of our kids have persistent symptoms over time. So if you think about in the practice that you see, if you see, 10 or 20 patients a day, how many of those kids are likely struggling if you're serving a chronic illness population? So I never like to give these talks without thinking about ourselves a little bit as well, and thinking about, as medical providers, what are the things that we are battling as we're taking care of kids that, and seeing kind of challenging things in terms of our practice. This study is old now, 2009, so it makes me feel older saying that it's old. It's been a while. It's pre-COVID. So these data are fairly low. I leave this study in here because this is one of the most comprehensive and included pediatric hospital providers across the spectrum, including physicians, PT, OT, speech, psychologists, like kind of a broad spectrum, nurses, all kind of boxed into here. So, and when we are talking about compassion fatigue, the definition for that is the secondary traumatic stress symptoms. So having PTSD symptoms in context of the work that you do. Some of the studies that we've seen come out more recently have rates of 50, 60, 70, 80%, depending on the roles. We know for some of the medical providers, like in the ICU and in the ED, some of that nurse data looks like, 80% are at risk for burnout. Our physician data has been steadily climbing as well. So keeping in mind that as we're thinking about these emotional responses in our kids and our families, to also keep our own emotional health in mind as well. This is very similar to what we see in our families. We expect, we have challenging patients probably every day, I would imagine, in most of your practices. And you know what to do with that. You have one challenging patient, you might have some distress about that, might have some stress. Often we can bring that back down. Sometimes we get a challenging patient that's so challenging that it's really hard to kind of bring that back down. Or you see a kid or a family that's going through something that just kind of gets stuck, and we have our distress persist over time. Some of the most common things that have been shared with me over time and working with medical providers is they have a lot of challenges with the really bad non-accidental trauma. So in cases of abuse, some of those get stuck more readily, or sometimes you have a really close relationship or a strong relationship with a family, and then you see them go through something really tough. So sometimes, even seeing what those families or those kids are going through can get stuck for us too. Same as the family, some of us have distress that kind of goes up over time also. But then for our work and the things that we do, we rarely have one challenging patient in a day. Often there are several. Sometimes the parents can be a lot more challenging than the kids. We all probably have experienced some poor patient outcomes over time because we know, things happen along the way. Sometimes maybe there'll be something else that's really challenging for you. It could be an injury story. It could be something that's happened with one of your patients that you connect with in terms of your own family or kind of your own experience and whatnot, where it just kind of gets stuck. So sometimes then our distress gets stuck. The other thing is healthcare providers, that's really important to keep in mind is we have this in our work life, but then we have our own personal life as well. Sometimes we have tough relationships going through. Sometimes we might have a death in our own family. Maybe our own child has a bad injury, or we're getting called from the school to come pick up Johnny because he put gum in Susie's hair, and you're in the middle of a work shift and you can't figure out how to get your kid and how to navigate it all. You might be having a problem with your own child and navigating that. So as healthcare providers, we're bringing in everything that we have from the outside, as well as these challenges that we have along the way within the context of our job. So things that we often see from healthcare providers, a lot of healthcare providers have shared with me over time, one of the challenges is sleep. It messes up sleep pretty good. This is from a trauma-informed care study that we had done a while back, and things that we shared, nightmares, kind of dreading. We all have those families that we serve where maybe it's a hard one. You see them on the schedule and you're like, okay, take a deep breath. They're coming in again today. How are we going to manage this? How are we going to best care for this family? Having this one case that just stuck with me, I think is very common for most of us. Most of us can kind of think back to a really challenging case that hit us in a different kind of way. It's not always real predictable what that would be. Sometimes it's real obvious, oh, that was a really bad situation. I understand why it's sticking with me. Other times there's just kids or situations that kind of wiggle their way in, and it's not as obvious, but can kind of just get stuck for us. So today we're going to talk through this case example of Sam. So Sam is, we'll say, is a 5-year-old male, generally healthy, no significant medical history. So this is not a kid that's coming in with chronic stuff, and it doesn't need 100 appointments. Just coming in, general well checks, pediatrician, has really strong family support, has some fear and nervousness though towards all medical appointments. We're not really sure where it came from, and he's refusing to participate in medical care. We chose this story because this is one that sometimes we miss when we're trying to identify kids that might need more support. The kids that I more regularly get consulted about at UK, and that I think medical teams are more aware of, is, if they're fighting and screaming about their appointments, if they have chronic stuff, if they have other mental health history. Those are the kids that are we're more aware of. These are the kids, the ones that are kind of quieter in the background, not participating in care. These are the ones that sometimes we're just kind of muddling through without the realization that, like, oh, this could be trauma for this kid too. And we might be able to do some things to help this kid along the way to make it better over time. So we'll talk more about that as we progress along. Let's spend the next few minutes talking about how do we recognize emotional trauma symptoms, both in our kids that we serve, parents and family members that we serve, as well as in ourselves and in our staff that we might be supporting. So when we talk about medical trauma, we're really talking about traumatic stress symptoms. So this is it is divided up into these 4 different characteristics. For re-experiencing, that can look like in kids, sometimes that comes out in their drawings, sometimes it comes out in their play, sometimes they might be talking about something over and over again. Re-experiencing can also be that full-on flashback where somebody actually feels like it's happening again. For kids that have scary medical diagnoses, I think a lot of parents in particular get stuck with that initial diagnosis where they heard the word cancer, or they heard, some kind of really challenging medical diagnosis, and then they go blank and they don't hear anything else. It kind of permanently sits with them. And that can come up in different kinds of dreams. For kids, sometimes we see dreams that are bad that are not necessarily tied to the event. For adults, usually it's related to the actual event and the medical care that's going on for their kid. For providers, it can look the same as what it does in other adults. Things like you can't get the case out of your head, you're going out to dinner and you're talking to a friend and this is just popping in. Other symptoms, avoidance can be something that's particularly important here to recognize. Avoidance can be things like trying to block it out, trying to stay away from it. Sometimes we see it in kids, them fighting about getting in the car to come to an appointment. Some kids, if you do inpatient care, might be fake sleeping when you come in the room, or not making eye contact, or just trying not to engage with you. For parents, this is really tricky because if we have parents that have really bad trauma reactions and avoidance, sometimes they might not be following up with their medical appointments for their kids that we want to. So keeping this in mind, if a parent is having a hard time making medical appointments, is something that could be going on. Sometimes, especially if our kids are inpatient, if people are rounding, some of those families that we seem like we can never catch might be avoiding intentionally because it's too distressing to talk about the things that are going on with their child. For medical providers, sometimes this is calling out of work more, trying to avoid certain kinds of patients, trying to avoid talking about things, kind of pressing it all down. We are really good as medical providers often of shoving it all down and going on to the next patient. So we just need to make sure that we get that back out and don't just shove it down permanently because it will come back out one way or another eventually. Other symptoms, changes in general cognition. So some of the things that happen when people experience trauma is we can kind of shift our worldview to thinking the world is a really scary place, or all things are bad, or all people are bad, or really focusing on the negative challenges in the world. Getting kind of stuck with some of those thoughts. Sometimes those cognitions or mood changes can also be a kid that used to be kind of bubbly and engaged, kind of withdrawing more. Sometimes we see more irritability and those kinds of things as well, more anxiety. Increased arousal can be particularly challenging in the medical context if we're trying to evaluate what kind of their vitals are. For example, if you walk in the room and their vitals shoot up and you can't get a good read. We had done an intervention in one of our clinics years ago. This was not when I was at UK, where they were having difficulties because all of the kids' vitals were elevated at a rate that didn't make sense to the medical team. And we did some interventions in there and changed some of the kind of environment of where they were taking their vitals, gave a few techniques to the medical technicians that were doing the vitals, and saw significant reductions across the practice in vital elevations. So thinking about how that could affect the way that you are in your assessment of kids and families. Some of these kids, when you open the door, they might jump, they might have trouble concentrating, might not be able to sleep. Similar for parents, might have trouble settling down at night, feeling really jumpy, or being in that increased agitation state, that fight or flight state. One of the things that I think is always really important for us to take a look at is if we as medical providers are in this heightened state, and so are parents, when we go to interact around a very stressful situation with our kids' medical care, that can lead a foundation for the conversations to not go as well in both directions. Parents might snap, medical providers might be less patient, so kind of keeping that in mind as we provide care. So one really kind of big thing to keep in mind as you serve kids and families, and as you look in, even if you're looking at symptoms for yourself, one of the most consistent findings that we have across medical trauma is it's not the severity of the exposure, but the severity of the medical condition. And it's not an obvious common sense indicator that predicts who is going to go on to have more emotional trauma. It's really, how does the child experience their medical care? How does the parent experience the medical care of their child? And how do they experience their disease or their diagnosis? That really predicts forward as to who's going to need more support and interventions over time. So this is available on healthcaretoolbox.org if anyone is interested in following up on this. This is a description of what we see trauma reactions in medical providers. So different things to look for in yourself and in your team. Things that I think are, if you look across the board, if you're not motivated to address potential trauma symptoms in yourself for the sake of yourself and living that good life, thinking about looking at how these kinds of reactions might affect the way that you're able to deliver care to your patients and families. So you can grab on to being an amazing clinician and try to address some of these symptoms, thinking about how could that affect your care moving forward. So thinking about the case with Sam and kind of what would that look like and what symptoms were we seeing in Sam. So there's kind of general mood changes and challenges we're having in Sam is he's got some pretty big anxiety going on in context of medical care only. Avoidance, he is trying to resist procedure, refuses to engage with the medical team. So he doesn't, he just kind of wants to keep to himself and like pretend it's not happening, fights the procedures. He has that hyperarousal, that anger and that irritability piece, trouble with fight or flight. So he's really in that elevated physiological state when we go in to examine him, when we go in to do needle sticks for like vaccines and whatnot. Some of it comes out as anger. So sometimes he appears more oppositional rather than anxious, but we know because we've, done an assessment with Sam by this point that it's actually some anxiety going on and it's getting into that panic place. And then he has constant worries about his appointments. So if he knows something's coming up, he'll, ask his mom about it for a couple weeks ahead of time and just worry about what's going to happen and how's it going to be and kind of have those worries over and over again. The other thing to keep in mind is when we have patients that are challenging like this, and particularly if we have a whole bunch of them all at once or in clusters, it can be really challenging for Sam and for the medical team as well. In addition to the family, we don't like to have to hold our kids to do procedures. We don't like to have to fight with our kids. We don't like our kids to have to be crying and upset every time they see us. It can be really hard. Like if the nurses are having a hard time getting him to do what they need to do. He's fighting during the medical exams. He's having challenging building trust with the medical team. And so sometimes what this results in for this kiddo here, some of the nurses are trying to minimize their interactions. So rather than trying to go in and develop relationships, they're trying to just get it done, get out of there, and like try not to interact with Sam. When we have a whole cluster of these kind of building up, this can also take a toll on our medical teams. If you have to deal with a whole bunch of kids that are unhappy and don't want to see you and are kind of fighting you throughout the day, it can be really stressful and lead to some more distress in the medical team. I am going to turn this over to Annie. So she's going to talk about some strategies of how to manage these patients as well, and how you can apply this to your practice.
Thanks, Megan. So with that, as healthcare providers, what do we watch for, and how should we plan or frame our response to all of this? We really want to ensure we're building a culture that fully tries to integrate knowledge about trauma into policies, procedures, and practices in our respective clinical settings. Next slide. So we do this in a couple of ways. Initially, we want to make sure we're minimizing traumatic aspects of medical care. We want to ensure that we're being mindful of whatever the patient or child's experiences to healthcare may be. So maybe it's not, maybe they're not a patient that's been chronically ill, but their grandma's been sick and in and out of the hospital a lot. Or maybe they've recently had a family member die in the hospital, or from a chronic medical illness that really has framed their perception of medical care and what that looks like. We also want to try to be mindful of treatments and procedures that we're organizing and scheduling for our patients. So with this, it's best to try to cluster and combine things as possible, minimize needle sticks or lab draws, perhaps combine appointments to help with continuity of care and kind of having everything all happen to one trip to whatever the medical facility may be. And then also just be mindful of the language in our interactions with our patients and families. So often, when a child's getting a vaccine or any sort of like shot or injection, like as a nurse will say, well, I'm going to go in and like, rather than give this patient a shot, like shoot this patient in a sense. And all of that, like with our culture and everything, it just isn't mindful as to how the child and the patient may be perceiving that. And in the same respect, children that get scheduled for like procedures that may require sedation. So often we say, we're going to be putting you to sleep. And if the child's experience prior to that is maybe with putting a family pet to sleep, their perception of that's going to be entirely different than what our intention with a saying that is. So those are just things to be mindful of. And then in conjunction with this, we also want to watch for and screen for high distress or high risk patients. With this, we get into talking about the number of like ACEs a child or patient has, which ACEs stand for adverse childhood experiences. And these things kind of build on one another. And it can be things like a child having a caregiver with a drug or alcohol abuse history, or a caregiver with mental health issues. Sometimes, single parents with multiple people in and out of the home, or physical or sexual abuse. It could even be something like the caregiver being neglected as a child, and then kind of based on how they were raised, I don't know, they're raising their child in that respect, and just have a low ability to cope with situations. So those are things we want to like screen for, get to know our patients, kind of try to dive into those details. And it may be where we need to really talk with their caregivers and offer guidance as to how they can help their child cope if they're screened for these like high distress, high risk, or as a high distress, high risk patient. So with all of this, I think it's important that we stand back and just kind of reframe our approach to this. So often we'll get report or talk to a member of the healthcare team, and in your report or what you're given, a lot of times you get a little bit of opinion with that too, and that can be a good or a bad thing, but it kind of skews your view when you go to walk into a room and try to determine those things with yourself, or on your own, I should say. So with that, an example that like struck me early on as a nurse, when I worked over in the children's hospital here, was that I had received like report on a patient that was in foster care, and it was a family we knew, or other people knew, I should say, and they were really well respected. They took very good care of these medically fragile children that they fostered. And I walked in the room and normally like have no trouble trying to establish rapport with families. And I just didn't get the same vibe. Like after I went in, had a conversation with caregiver, when I walked in, I could tell, the patient really was withdrawn, wasn't making eye contact with me, that sort of thing. And after I had like given meds and left the room, and I had gone down to like my next patient, the caregiver had come out to the nurse's station and had asked for me to be removed from the patient's care because I looked like the patient's biological mother. And with that, that's something, walking into the room, I would have never known. So, it was a difficult thing for me as a nurse, but I can only imagine the effect that also had on that child, being in the hospital for help and how they must have felt. So with that, rather than really framing this as in the light of, what's wrong with this patient or family, you really have to be mindful as to what has happened to this patient or to this family, and how do we help them like moving forward from this point on. So with this, as healthcare providers, we love the ABCs. And after we kind of get everything acutely managed, we can move on from the ABCs and consider the DEFs, which I'll touch briefly on these here, but we'll get into them more on the next slides. The DEFs, distress, emotional support, and family. So with that, how do we assess the first one, distress? What do we look for? Sometimes it can be hidden as like high functioning anxiety. Sometimes, like Dr. Marsak spoke to earlier, it can look like a child being very withdrawn, and maybe just not in their appointments, but also withdrawn from things that they used to enjoy and used to love. Our patients can be distressed and be like moody or irritable. Maybe they're routinely expressing a worry, or they come into our clinic appointments and are exceptionally clingy to whoever the caregiver is with them. They could have changes in their eating or sleeping patterns. They could be more, they could cry more and be more tearful. And you can really see that fight or flight response some. So with that, how do we help these kiddos? So a lot of times, initially, it's nice to let the child have as much control as possible. This can include things like, which arm would you like your flu shot in? Or because they definitely need the flu shot. You want to establish that that is something that is going to happen, but they can take ownership over the location, and maybe interventions used such as like freezy spray, lidocaine cream, like squeezing a stress ball and things of that nature. You can also give them, a lot of times, give them the option to have a countdown, and with this, continue to actively assess and treat their pain. So going into all this, you really, another component of this, sorry, someone just walked into the room I was in. So another component of this is when you go to explain the medical procedure or what's transpiring with the patient you have at hand, you want to ensure you're going through and explaining everything in terms that you think are relevant and appropriate for the child. And we focus on teach back a lot for the parents, but we also want to focus on teach back for the patients. And I have a kind of a really good clinical example of this from when I worked over in the hospital. And it included a little girl that had broken her arm at school, and she came in and we managed her pain well. She was very playful, like didn't complain a lot. Went to the OR, had it set, came back up to the floor, and we continued to manage her pain with oral medication. I went in when she had discharge orders. I went through discharge teaching and that sort of thing with her and her mom, and talked about in her follow-up appointment what to expect, that she'd be going into a clinic, and when it was time for her cast to come off from her broken arm, they'd be using a saw, as they call it, but it wouldn't be something that would hurt her. It would only cut the cast and that sort of thing. And I felt like I had done a decent job explaining that. I had printed off the education, the pictures, and all of that. And as they were discharged, I had walked this family down to their vehicle, and just in walking with them and talking to them, I asked the little girl if she had any questions. And her response to me was, so when are they going to cut it off, like my arm? And with that comment, I realized, that I had failed, that I thought I had done all of these things appropriately, like I had been instructed and taught. However, I had really failed with communicating and getting her perception as to what was going on with that. So just additional things to be mindful of. The next is emotional support. So with this, we want to keep track of what works and what doesn't work. And with this, identify the child or patient support. So who's their caregiver? Maybe do they do better with the grandparent, or maybe they have an older sibling that when they come in for their appointments and things is able to distract them more than their mom, say if their mom's anxious about whatever's going on. You want to consider friends at school and maybe on sporting teams and things like that. So if you have a child that comes in and is maybe having anxiety because they had a broken leg, and then when they go to start back in their activity, maybe where they were injured, there could be a lot of anxiety with that, rightfully so. So ensuring they have support from their friends, their family, their coaches, and people like that are really vital to all of this. Another example is kids with food allergies a lot of times have other friends with food allergies. So I know I've been involved in discussions with the patients of ours where they talk about if what they would do in the event of a reaction and using an EpiPen and things of that nature. Additionally, so to the DEFs, the F, we will dive into family needs. So we will assess the family, the caregivers, the siblings, by potentially asking them about have they or another family member ever been upset about a medical experience, or are they having an exceptionally difficult time trying to deal with their medical trauma or an experience? Maybe are there other stressors going on in their family right now? Maybe a parent has lost a job. Maybe there's some financial burdens. Maybe they're having trouble paying for medications, things of that nature, offering them social support and needs that are beyond medical. Also helping them look for support maybe outside of their family and in the community. That can be maybe through clergy or their church or support groups, after school activities and things of that nature. So these are all things we can be mindful of, and ways that we can continue our support with medical trauma in our pediatric population that are outside of the clinic, outside of healthcare, in ways that are also very vital and important to the patient. With all of this, we also want to be mindful to provide culturally sensitive trauma-informed care. And this can look different for everybody. We really want to be mindful that we resist re-traumatization, and we can do this in a number of ways. So we want to ensure that we recognize cultural variations that can include things like treating, I know the certain ethnicities will try to treat illness with maybe certain foods or certain temperatures of foods that can make children resistant to that when they're not sick. We want to listen to beliefs and the interpretation of what trauma may look like from people of different cultures, and who they may see as their healers in a sense. We want to be mindful to, restore safety and trust building. And this may include things when kids receive care outside of what we have control over. And like I mentioned earlier, like if you have a teenage patient that perhaps has broken a leg with a sports injury, really setting him or her up for success to get back to doing what they love and that sort of thing. We also want to address stress in the way that the patient and family identify it or define it as. So be mindful and respect their wishes and what they want. Integrate the family's understanding of their diagnosis, their prognosis, and healing into their treatment and planning. So with our trauma-informed care actions, we'll get back to the case example of Sam. So how do we plan the DEs and Fs for Sam? Well, for distress, I think we're clear on why he's coming in. We don't need to keep it a secret or spring it on him. You give him the choice, say he's coming in for his flu shot, like we discussed earlier. And and as Dr. Marsack spoke to, that he has a needle phobia. Well, giving him the choice of which arm, maybe making an incentive with parents. I know sometimes we'll hear like, if you do well with this, we'll go to Malibu Jacks later. And with that, don't be afraid to not give the incentive if the goal isn't met, because we want to continue progress and work in a positive direction and not like reinforce the medical trauma in a sense. We want to provide Sam with emotional support. So a lot of times this can look like having like a primary care team, whether that be a physician or a nurse that they routinely see, that they build and establish that rapport with and those relationships with. And then moving on to family support. You want to assess the parent distress. Maybe the parent has a needle phobia that's playing into Sam's needle phobia. So sometimes it may be better if they sit down, or if they choose to maybe leave the room and have a sibling with Sam. Those may be other things that are beneficial with that. So I think the key things here are with this, coming out of these experiences, for us as healthcare professionals, all of these traumas that our patients experience play into what we experience too. So how do we take care of ourselves? Well, there's not a one size fits all answer. There's not something that's going to work well for everyone. And with this, we want to ensure that we personally know what our limits look like, and are able to recognize distress, burnout, and ourselves and our peers, and really watch for when we have that disrupted work-life balance. So with this, as healthcare providers, we love the ABCs. And in self-care for us, why not remain the same with ABCs for awareness, balance, and connection? So awareness of boundaries, awareness of how you respond to things at work if you start snapping or short, or if after you leave a long day, you're tearful. These are all kind of red flags to watch for with that. Balance for us, balance can include things like going to get coffee with your peers, or taking a sunshine break, or maybe even going, instead of sitting at your desk for a meeting, doing a meeting via like a walk around campus, and using your vacation days, and when you're on vacation, actually like unplugging and and taking that vacation day. So, and then the last one, connection. And this is one where when you notice within yourself that you're starting to cancel life outside of work, where you're not meeting up maybe with friends or family for dinner, or you're not able to make it to church or do things that are important to you. Those are key indicators that you need to take a step back and reflect. So here's a self-care wheel that itemizes ideas based on responses that can be physical, psychological, emotional, spiritual, personal, and professional. So just ideas, tips, and tricks to be mindful of with that. If we're not our best self, it's hard for us to help anybody else. So, and with that, like I was kind of alluding to earlier, when do I get more help? Well, is work getting in the way of life, or is life getting in the way of work? When you have thoughts about self-harm or harm to others, or when others voice concern. And then that takes us back to Sam and his medical team. So with this, as we have healthcare teams that have all sorts of different levels of experience and backgrounds with experience, it's important to have conversations and educate one another on these traumatic stress reactions. It's also important to schedule time to debrief after experiences like these, and we think of debriefing as only being when something doesn't go well, but it's also important to debrief when things go well and discuss what went well and maybe why it went well. You also want to facilitate a culture that promotes seeking support, whether this be like a buddy system for lunches, or like when you have a difficult patient coming in, having someone go in to help, to be your support. And in this specific case, if Sam's caregiver's a support, it's okay to have someone come in with you and identify them as your support to Sam in a sense. it's also important to create systematic workflows. And with this, if you have a kiddo coming in that you think it is going to have a difficult experience with the procedure or an appointment, it's probably best to schedule them at a time when clinic or wherever is not so busy, and the kids around them aren't going to hear the screams and things of that nature. And after scenarios like this, you create that systematic check-in, and then identify resources that are accessible to both other staff members and patients. So with that, Dr. Marsak's going to get into talking about resources here briefly.
Thanks, Annie. That was a wonderful, very quick overview. And what we're hopeful is that this will get you interested in integrating some trauma-informed care into your practice, and then you will reach out and do some additional training as indicated for your team. We only have a couple minutes left, so I'm going to flip through these resources fairly quickly. Like Michelle said, this will be emailed to you, so you will have access to to look at these resources more closely. This is one of the resources that we talked about quite a bit through here. There's a lot of free downloadable resources on Healthcare Toolbox. There's some additional free CE courses here as well that really dive more into medical trauma. Some screening resources if you're looking to integrate systematic screening into your practice. Some free downloadable in Spanish and English handouts to help kids cope with medical care. It's a resource for parents of kids that have had injury. Again, a website that's available. This is a book I wrote around how do you navigate medical care for your kid. I co-wrote this with a mom of a child with Hunter syndrome, and so she really brings the parent perspective into that as well. This is for kids with cancer, the SKIP program. It is shortly going to be available, I think, via internet electronically as well. Currently, it's an in-person training and whatnot. The Celly Coping Kit is a resource that we have for a number of different medical conditions that's meant to be used by kids and parents. You can take a look at that. This one might be of interest if you're interested in trying to promote self-care and prevent trauma in your own systems. These are tools that you can download and do the training with the teams that you work with to promote emotional coping in healthcare professionals. And there's some other resources here. Some UK specific resources listed here as well. And then some upcoming trainings here. I think we have time for one or two questions, Michelle, if we have any that are in the chat, and otherwise we will get it wrapped up. Thank you so much for joining us.
That Megan's showing you right now is our upcoming PEDS ground rounds that are open both internally and externally to providers. So we've got those through the end of the year, and we'll include that in our follow-up communication. If you haven't put your name and your email address in the chat box, please do so that we can get all these resources to you so they can see the upcoming activities that we have. Does anybody have any questions? What do you consider, Megan, the first step when you're trying to set trauma-informed training up?
So I think thinking about for your teams, where are the difficult points? What is the hardest for your teams to burn out a big problem? So identifying kind of what are you going to work.
I'm sorry, Megan, you're freezing up.
Yeah, I'm getting some special messages from Zoom over here. But I think identifying what your goals are, identify where your problem spots are. If you want to look at Healthcare Toolbox, there's a lot of resources there to get you started. And then the Center for Pediatric Traumatic Stress also does consultations with teams as well. If it's something that you're interested in, you can reach out and we can chat further.
Sounds great. Thank you, everybody, for joining us today. We appreciate it. So we will, I think we've got another one coming up in December for another PEDS Town Hall for community-wide, and we'll be sending that information out to you as well shortly. Thank you again today from Megan and Annie. We really appreciate it.
Thank you.
Thanks, everybody.
Thanks.